Okay, Assalamualaikum and a very good morning. My name is Ihsan. I'm the registrar from the ophthalmology team. So I'll be starting the presentation this morning for our CPC, and the title is Blinded by Pressure, Unveiling the Ocular and Renal Consequences of Severe Hypertension. All right. So I have a case. This is a 42-year-old Malay male with underlying end-stage renal failure secondary to mixed glomerulonephritis, chronic hepatitis B with liver cirrhosis, hypertension, and he came complaining of left eye sudden onset painless blurry of vision for the past 2 months. So for the subsequent history, so the onset, it is sudden onset, painless, mild blurry of vision, which he complained preceded with floaters, which he realized the floaters while watching television. Initially, it was small dots, but it progressively increased in size over time. And 1 week prior to presentation, he said that the left eye blurry of vision significantly worsened, and the patient complained of new onset painless right eye blurry of vision, thus came to seek treatment. Otherwise, there are no other related ocular complaints such as redness, discharge, itchiness, lid swelling, headache, nausea, vomiting, metamorphosia, flashes, a history of trauma to the eye or head, or history of recurrent blurry of vision, meaning that this is the first episode. There is no recent history of weight loss, loss of appetite, fever, prolonged cough or night sweats. There is no altered bowel habit, diarrhea, constipation or abdominal pain, no history of ocular surgery or laser done before, no history of facial asymmetry, slurred speech, limb weakness, no history of traveling, jungle trekking or swimming, and he owns 2 cats at home which are not vaccinated with multiple history of cat scratch. All right. For the past ocular history, he was initially referred from the nephro team back in November 2023 for eye screening during his admission for hypertensive emergency prior to his renal biopsy. So he was reviewed by ophthalmology team back then, and he was diagnosed of having grade 3 hypertensive retinopathy. And for his past medical history, he was diagnosed with hypertension back in October last year in Klinik Kesihatan, and he was started on amlodipine. Other than that, he also have end-stage renal failure, which is diagnosed 1 month after he was diagnosed with hypertension. He went to Klinik Kesihatan after having episode of shortness of breath, and then he was referred to HCTM for hypertensive emergency and noted to have acute kidney failure on CKD, and the differential diagnosis is rapid progressive glomerulonephritis. So it proceeded with renal biopsy in November 23 and shows that there's diffuse sclerosing pattern with mesenchymal proliferation and fibrocellular crescent, thickened glomerular basement membrane in areas with equivocal electron density are seen with the mesangium. So it may represent ischemic injury or deficits. So currently he's on hemodialysis, 1 and 5 via PEMCAT at private center. He also has chronic hepatitis B with liver cirrhosis, which is incidentally noted during admission in November 2023. Otherwise, he denies high-risk behavior and there is no history of blood transfusion. Other medical history, he has OSA and anemia secondary to end-stage renal failure. So these are lists of the medication patient is on, but unfortunately he was not very compliant to the medication as he complained of having dizziness after taking it. All right. So he has history of renal biopsy, as mentioned before, and for his family history, his mother has hypertension and diabetes, but no CKD. Father has dyslipidemia. He has 4 siblings, and 2 younger siblings has hypertension, and otherwise there's no family history of malignancy, blindness, or glaucoma. He is also allergic to amoxicillin, but there's no history of food allergy. So for social history, he denies high-risk behavior. He had a history of bekam, quite frequent for the past 4 years, and lived in Cheras. He was blessed with 2 children, and currently self-employed, and as he owns an IT company. All right. So when he came to us, he was alert, conscious, and cooperative. He has shallow skins, but comfortable on room air. So vital sign shows that the blood pressure was high. It was 180/95 millimeter mercury, with normal heart rate, temperature, and the respiratory rate was 20. So the lungs, CVS, and abdomen was normal, and there's no pedal edema, and the Pembincang side is clean. So on ocular examination, we noted that the right eye vision is 6/24, not improved with pinhole, and the near vision was N12. So for the left eye, it is counting finger. There is no RAPD noted. The extraocular movement is quite full, conjunctiva is wide, cornea is clear. Anterior chamber, right eye shows deep but pigmented occasional cells, and the left eye is quite deep and quiet. And the pupil was reactive and round for both eyes, with normal iris noted. There's no evidence of neovascular at the iris. The lens, both eyes are quite clear, and the IOP for both eyes are 12. So when we proceed with the fundus examination, okay, this is the fundus examination of the right eye. So we can see that there is multiple dot blood hemorrhages scattered all over the fundus. There's also dense, large area of exudates noted with, this is pre-retinal hemorrhage, okay, and this area there is presence of vitreous hemorrhage on top of hypertensive retinopathy changes. But there are no signs there are no signs for us to look for, like tortuous vessels or dilated vessels, to say that is CRVO or central retinal vein occlusion pattern or branch retinal vein occlusion. Otherwise, we cannot actually see clear for the neovascularization at the disc. And this is the fundus photo for the left eye. So there's very dense vitreous hemorrhage. So this is what caused the vision to be counting finger. Otherwise, the fundus and the retina is not seen. So from the examination of the fundus, the right eye shows macula is dull with scattered dot blood hemorrhages in all 4 quadrants. There's heart exudates present at all 4 quadrants with vessels sclerosis at the supratemporal area and vitreous hemorrhage inferiorly with large pre-retinal hemorrhage in inferotemporal fundus. The left eye, the fundus view is hazy with generalized dense vitreous hemorrhage. So we were thinking of a proliferative retinopathy at this stage. So what causes it? Yeah. So we proceeded with examination. We proceeded with right eye optical computed tomography to see at the retina. And this is the right eye OCT. It shows, all right. So this is the OCT of the right eye. It shows the cut of the retina, and the retina is a bit thickened. Here is the macular area. You can see the indentation at the fovea area here. And noted there is a lot of these hyperreflective dots, which may represent there is exudates or deposits here, and there's presence of subretinal fluid. Okay, so this is for the right eye. So there's no OCT for the left eye, as the view is hazy, and we proceeded with B scan of the left eye because there's no fundus view. So B scan is brightness scan. So we use ultrasound to have to see the structure of the left eye, and we noted that okay, this is the vitreous area inside the eyeball, which is hypoechoic, and there's dense hyperechoic area here, which signifying there is vitreous hemorrhage, but we can see a large thickened hyperechoic layer here. Okay, so this layer is the retina, and underneath the retina, you can see that there's some diffuse hyperechoic, which may represent blood accumulation underneath the retina. Okay, so these pictures of B scan shows there's some degree of vitreous hemorrhage and some degree of exudative retina detachment seen. Yeah. Okay, this is the retina that has been detached, the vitreous, and this is the area of the bleeding, the back. So what the patient is having now is some proliferative retinopathy and possible proliferative choroidopathy. So we need to rule out whether this is vascular cause or this is an inflammatory cause. And we proceeded with fundus fluorescence angiogram back in May. So it shows that the right eye, there's no AV delay, atriovenous delay. You can see all the macroaneurysm all over the fundus here, at the posterior pole and at the periphery. And there is neovascular at the disc, over the temporal part of the optic disc, shows by the leakage at the venous face here. All right. And there is neovascular elsewhere, the superior and nasal area, over this area. All right. And patchy capillary fallout area. So this is area of capillary fallout, meaning that there is ischemia going on. So we can see it at the superior part, superior temporal. Inferior part, there's a large capillary fallout area. And I can see also there is atriovenous shunts or collaterals here at the superotenasal quadrant of the right eye and at the superior part of the right eye. And there's no vasculitis seen, however. So we concluded that this is the late venous phase, showing that there is a large capillary fallout area for both superior and inferior part. We did send for blood investigation. Patient, however, is non-diabetic. Okay, the fasting blood sugar and the HbA1c was normal. Okay, FBC noted that patient to be anemic with PBF of normochromic normocytic with deranged renal function. LFT was normal. ANA was positive, but the titer was low, and it's speckled with negative dsDNA and negative ANCA and negative anti-GBM. The ESR, however, is slightly high. ANA also negative, and the complement C3, C4 is slightly raised. However, patient is non-reactive to HIV and also RPR. And the renal biopsy done was seen as diffuse sclerosing pattern with mesangial proliferation associated with fibroblascular crescent. So our impression at that time is left eye proliferative hypertensive retinopathy and choroidopathy by the evidence of left eye exudative retina detachment. There's presence of subretinal, preretinal, and vitreous hemorrhage, and the right eye proliferative hypertensive retinopathy evidenced by the preretinal and vitreous hemorrhage. So the plan next is, our aim is first to stabilize the blood pressure and the systemic condition. So we admitted the patient, referred the patient to the nephro team for BP stabilization. And for the ocular plan, we plan for right eye panretinal photocoagulation. And for the left eye, we did left eye surgical intervention. Okay, usually we don't do surgical intervention in the case of exudative retina detachment, but due to the left eye ocular problems, okay, and if we leave the left eye like that, then later on patient will develop complication such as neovascular glaucoma. Okay, and we need to monitor the condition and give the patient also intravitreal anti-VEGF injection and panretinal photocoagulation. So we decided for left eye surgical intervention. So what we did is Left eye, 25 gauge past planar vitrectomy, vitreous hemorrhage clearance, retinotomy, put in heavy liquid. We did fluid exchange, and we did endolaser and tamponate the retina with silicone oil. So intra-op findings, there's large subretinal bleed flowing, the subretinal fluid drainage, and there's vitreous hemorrhage with active bleeding, exudative retinal detachment. The vitreous was very adherent, and the hard exudates noted surrounding the major vessels. So this is part of video for the surgery. So we are inserting the pot for us to insert the instrument inside the eye. This is the infusion pot. So we are trimming the vitreous, now. So when we go in to see the retina, all we can see is hemorrhages all over, all right? So what we did is we trimmed the vitreous surrounding the hemorrhages first, on top of it, while cleaning the vitreous hemorrhage. This instrument is the cutter, okay? So it can both cut and vacuum out. So we stain the vitreous with triamcinolone acetate, okay, and continue cleaning up the vitreous. So then we can see the exudative retinal detachment located, evidenced by the bulging of the retina, okay, all over. And we noted the patient to bleed profusely inside the operation theater itself. So we tamponate it, we flatten the retina with heavy liquid while clearing up the vitreous and the bleed. And then what we did is we do, this is a retinotomy site, okay, where we did to actually remove the subretinal fluid underneath the retina. Okay, so that we can flatten the retina and we can put oil to tamponate on it. So the vitreous is quite clear now. Okay, there's still some active bleeding, so we laser surrounding the retina, retinotomy site, okay, to make sure later it will scar up around this area. Okay, and we did full pan-retinal photocoagulation, or we call it endolaser, intraoperatively. All right, and the last, we put in silicone oil to tamponate on the retina. Okay. So this is the post-operative fundus view after 1 week, meaning that the patient still bleeds inside the eye. Okay, so we tried, we actually, during the admission, we give heparin-free dialysis, and however, the patient is still bleeding. With the oil inside the eye, also the patient is still bleeding, but he claimed that the vision actually improved a bit from PL to 160. From counting finger to 160. Otherwise, the retina is flat, and we are still monitoring the patient. He will be coming today also for us to see him. So I think that's all for the case presentation. I would like to thank you, and back to Prof. Safinas.
Thank you, Mama Ihsan. I'll leave the question at the end for you, at the end of the session. So we'll call upon the next presenter first, Dr. Ainal Adlin, to talk about proliferative retinopathy. What could be the causes?
Assalamualaikum and good morning. Thank you, Prof. Safinas. So I will discuss about proliferative retinopathy in this page. Okay, so the outlines of my lecture, the first part is I will be talking about proliferative retinopathy, and the second part I will be talking about the hypertensive retinopathy, hypertensive choroidopathy, and also proliferative hypertensive retinopathy. Okay, what is proliferative retinopathy? As its name Proliferative retinopathy refers to growth of unstable new vessels on the retina as a result of retinal ischemia. And these new vessels, it tends to break because it is unstable, it is very fine and friable, and it will bleed on the pre-retinal surface. So we call it pre-retinal hemorrhage or subhyaloid hemorrhage, yeah, and also into the vitreous gel. When it bleeds into the vitreous gel, we call it as vitreous hemorrhage. Okay, first and foremost, we go to the retinal blood supply first. Okay, retina, it receives dual blood supply, which is from the central retinal artery and also choriocapillaries. If you follow the arrow here, the green part of the vessel here, okay, this is the central retinal artery, which is the first branch of the ophthalmic artery. So this artery, when it enters the optic nerve, it runs through the course of the optic nerve and it will pierce the optic disc and it will branch out to become superior and inferior branch first, and it further divides into superotemporal and superonasal and inferonasal as well as inferotemporal. And this central retinal artery, it supplies the inner retina. The second blood supply is from the choriocapillaries, which supplies the outer retina and also the retinal pigment epithelium. And microscopically, if you look at the arrangement of the blood vessels of the retina, it can be further divided into two capillary plexus, which is the superficial capillary plexus at the inner part, the more inner part of the retina, innermost part of the retina, which is near to the nerve fiber layer, and also it is arranged at a deeper layer, which is, it forms the deep capillary plexus. So what happened when the retina is ischemic? So for the retina to maintain its health, so the retina tissue needs the oxygen and nutrients. So when there is condition in chronic hyperglycemia in diabetic patients or in vascular occlusion, whether it is vein occlusion or artery occlusion and inflammation, this will put the ocular environment in oxidative stress, and this can lead to retinal hypoxia and retinal ischemia. So the ischemic condition of the retina, it means that the retina has lack of oxygen, but it needs to live, it needs to survive. So what happened then? So what happened is it produces growth factors. Okay, it secretes the growth factors. So there will be upregulation of especially the vascular endothelial growth factor, the placental growth factor, and also the pigment epithelium derived factor. So this upregulation of growth factors will stimulate the angiogenesis and form the new vessels in the eye. So now we go to the causes of proliferative retinopathy. So the common cause is the topmost. When the patients come to you with proliferative retinopathy, the first that you should think in your mind is whether this patient is diabetic that causing proliferative diabetic retinopathy, or whether this is vascular retinal vein occlusion, whether it is a central or branch retinal vein occlusion. So these two are the most common presentation of the patients with proliferative retinopathy. Then you go to the uncommon causes, which might still happen in this patient. So vascular, it still can happen in this patient, but less common causes would be central or branch retinal artery occlusion, ocular ischemic syndrome, and proliferative hypertensive retinopathy actually is very rare. Radiation also, especially in cancers like NPC or maxillofacial cancers also, and when patients receive radiation therapy, so this predisposes the ocular structures to have radiation retinopathy. In inflammation and autoimmune, they also have ischemic drive in the retina that can stimulate the new vessels formation. Eels disease and also sickle cell anemia, patient also can have sickle cell retinopathy. And in genetic disease also, they can develop proliferative retinopathy, such as in familial exudative vitreoretinopathy. So in fundus examination, in fundus photo, what you can see, the features, the evidence of ischemic retina is the formation of the new vessels. So where can you find the blood vessels, the new vessels? You can find it first on the disc, okay? And also you can find elsewhere at the retina. If you can see the arrangement of the new vessels, okay, it is not arranged properly in how the normal blood vessel grow. You can see this these vessels are fine and arranged in haphazard manner. Okay. The other method that you can see the nerve vessels is by using fundus fluorescein angiography. But this technique is invasive, in which the patient will be injected with fluorescent dye into the systemic circulation, and the dye will go to the systemic circulation, including the eye. So when the dye goes to the eye, we will capture and we will record how the blood flow, how the dye flow to the eye, and we will capture what the pathology that happened in the eye. Like in this patient, you can see that the darker part is the area of the capillary non-perfusion, and you can see some leakage from the nerve vessels at the inferotemporal structure, which indicates this patient is having ischemic problem, which is more localized at the inferotemporal region. So what are the management options for this for the patient with proliferative retinopathy? So the aim of the treatment for the patients actually to reduce the oxygen demand, so that we want to reduce the nerve vessel formation. So what we can do? So we can offer patient laser photocoagulation, in which when the laser spot hit the retina, okay, it will kill some part of the retina at the periphery. We need to spare the center part of the retina, because this is the macula, which is the most important part for your vision. So where we laser the retina is at the periphery. So this will reduce the oxygen demand in the retinal tissue, so it will reduce the nerve vessels formation. Second is the options of anti-vascular endothelial growth factor, in which this will be given in intravitreal, means we jab the patient's eye into the eye. So this anti-VEGF medication, it will reduce the VEGF production, and it will regress the nerve vessels. And the third option is pars plana vitrectomy in the case of we cannot see the fundus because of media opacities due to the vitreous hemorrhage. So when we clear up the fundus, then we can deliver laser photocoagulation into to the retina, like how Dr. Ihsan showed you just now. Okay, this is the second part of the lecture, which composed of hypertensive retinopathy, choroidopathy, and also proliferative hypertensive retinopathy. So eye is the only organ in the body where the vascular changes due to systemic hypertension can be observed in vivo. Okay, so how does it occur? So this hypertensive retinopathy, it has three phases. The first phase is the vasoconstrictive phase. So what happens in vasoconstrictive phase is the arteriola is narrowed and it becomes vasospasm to reduce the blood flow to the retina, and this is due to the property of the retinal vessel, where it has autoregulatory mechanism. Then second phase is the sclerotic phase. Sclerotic phase, what scleros here? So it's the blood vessels, okay? So there will be changes in the endothelial wall, where there is intimal thickening, medial hyperplasia, and also hyaline degeneration of the arterioles. And the third phase is the exudative phase, when there is disruption of the blood retinal barrier, and it will leak out the plasma and blood. So if this fluid, where does it accumulate? Usually at the posterior pole. Patient can have macular edema, and also in severe cases, patient can have exudative retinal detachment. Okay, for the benefit of medical student, okay, this is the classification of chronic arteriosclerotic hypertension. So this grading is about the arteriosclerosis. So focus on the vessels, okay? So after this, because after this, I will explain regarding grading of hypertensive retinopathy. So with arteriosclerotic changes, okay, the stage 1, if you can see, this is the normal blood vessels. You can see that this is the vein and this is the artery. In stage 1, you can see the widening of arterial light reflex. You see, if you compare the normal arterioles here and this arteriole, you can see that in the arterioles, okay, there's slightly a streak of whitish streaks inside. So that's how it looks in the stage 1, widening of the arterial light reflex. And stage 2 is the AV crossing. So you can see here the artery, okay, it crossed the vein and caused AV crossing here. And stage 3 is the copper wiring of the arterioles. Okay, this is more severe stage where the artery, you see the inside, the hyaline degeneration, the sclerotic phase here. Okay, it looks like a copper wire. The color is copper. If compared to the grade 4, the grade 4 is more severe, then it becomes silver wire. Okay. Okay, this is the grading of hypertensive retinopathy. There are few gradings that we can use. The famous one is the Shire classification. Other classification you can use Keith, Wegener, Barker, or Wong and Mitchell. And the latest one is there is no name, but the classification is based on optical coherence tomography, where they are looking at the fluid at the macula as well. So according to Shire classification of hypertensive retinopathy, so grade 0 is no changes, it's a normal vessels. Grade 1 is barely detectable arteriolar narrowing, that's vasospasm of the arterioles. And grade 2 is a obvious, the arterial narrowing is more obvious, like the silver wiring, yeah. Also AV nipping presence. Grade 3 is grade 2 plus the retinal hemorrhages, okay, like dot blood hemorrhages, flame-shaped hemorrhages, yeah, presence of cotton wool spots. The presence of cotton wool spots indicates there is microinfarction of the nerve fiber layer, and also there is presence of retinal edema as well. And grade 4 is the combination of grade 3 with papil edema, where you can see there is optic disc swelling. So when the patient comes to you with hypertensive retinopathy, what is the management? What should you do? Actually, there is no specific management, no specific ocular management for this patient, but you need to control the blood pressure. So when the blood pressure is controlled, the changes is reversible. Okay, and hypertensive retinopathy doesn't require screening in asymptomatic patients, unlike in diabetic retinopathy, where patients need regular follow-up for that. Okay, the second part is hypertensive choroidopathy. Hypertensive choroidopathy is not common, okay, and it usually occurs in combination with hypertensive retinopathy, and it is usually seen in younger populations with acute elevation of the blood pressure. Why? Because the blood pressure in young patients, they are more elastic as compared to the older patients, where there is arteriosclerosis happen. Okay, first you go to the anatomy of the choroidal circulations. This is the choroidal stroma, and this is the choriocapillaries. And you can see here the blood vessel is supplying the choriocapillaries from the outer part, from the stromal part of the choroids. So as you can see here, the blood vessels initially is larger, and as it goes to the choriocapillaries, it becomes smaller. And this is the cross-section of the choroid layer. So the outer choroid, the vessels are larger, we call it hallux layer. And the second layer is the sacral layer, is a medium size, and choriocapillaries is rather small. So when we are talking about hypertensive choroidopathy here, we need to see the anatomical structure of the choroidal arterioles itself. When the choroidal arterioles supply the choriocapillaries, it gives a right angle to the choriocapillaries from the outer vessels. It means that the BP is directly transmitted to the choriocapillaries, which leads to the non-perfusion state. And the second one, the flexible property of the choroidal arterioles, it will undergo the vasoconstriction, also vasospasm, which can lead to choriocapillaries non-perfusion as well. So these two are the theories why hypertensive choroidopathy happens. So that when there is acute elevation of the systemic blood pressure, it will cause fibrinoid necrosis of the choroidal arterioles. So what happens is there is ischemic along the choroidal lobules, yeah, and this will appear as the linear hyperpigmented streaks, which we call it as Sigris streak. And furthermore, it leads to the non-perfusion of the overlying choriocapillaries. Then the fibrinoid necrosis of the choroidal arterioles also, it can lead to focal ischemic damage to the overlying RPE, because we know that the supply of the RPE is from the choriocapillaries. So it will appear as a yellowish lesion, we call it as Elschnig spot. So in chronic condition, when it becomes chronic, the Elschnig spot becomes a darker color. It's become like a blackish spot. And in more severe BP elevation, it can lead to pigment epithelial detachment and also exudative retinal detachment. So as you can see here, okay, the yellowish lesion in early phase of the hypertensive retinopathy, it can appear as a yellowish spot. So in late state, it can appear as a snake spot. And the linear streaks are the Segre streak, and this is the in severe elevation of BP, it can lead to exudative retinal detachment. Okay, proliferative hypertensive retinopathy is rather rare. The term is quite new. It's first introduced in 2014, and to date, it's only 4 case report available for proliferative hypertensive retinopathy case. There are few papers that was 4 papers. So in 2016, 2014, 16, 17, also 19. So if you look at the profile of these patients, they are rather young patients. There is no gender predilection. If you can see, I mean, yeah, it's a small numbers of cases, but there is no gender predilection. And if you see the cause of the hypertension, it can be either primary or secondary hypertension. At presentation, the BP is like sky high, okay? And at presentation also the vision, only in the first case that the vision is okay. I mean, the outcome is okay. Comparatively better than other cases, okay? At presentation, their visions are poor, counting finger, hand movement, yeah, and they can present with vitreous hemorrhage and also tractional retinal detachment. So treatment that has been given so far, they only give intravitreal anti-VEGF and also pan-retinal photocoagulation, because as I mentioned in proliferative retinopathy treatment, these are the management options that can reduce the VEGF production in the eye. Okay, and the outcome is not a favorable outcome. Okay, the vision didn't go back to a normal state of vision. The vision is only a partial recovered. And some patient progress to complications like neovascular glaucoma. So what are the postulations? They said because these patients are young patients, okay, so the blood vessels are more pliable and flexible as compared to the elderly, and also presence of autoregulation in the retinal vessels. So the retinal vessels able to maintain longer vascular tone as compared to the choroid. So therefore, the retina is expected to withstand a higher BP longer and choroids before develop significant ischemia. So what are the management of proliferative retinopathies, hypertensive retinopathies? It is same like hypertensive, proliferative, the other causes of proliferative retinopathy. But the role of vitrectomy, the role of surgery is still questionable actually, because no one, according to the case reports, no one did vitrectomy before. But like Dr. Ihsan said, in our case, we can't monitor, we don't know what's happening in the retina. We can't monitor the patient and we can't treat the patient. So that's the reason we opted for surgical intervention, so that we can deliver the treatment into the ocular structures and monitor the condition and to avoid the complications of the ocular problem. Thank you.
Thank you, Dr. Ainal. So the eye is an organ with microvascular circulation, and now I like to invite Dr. Muhammad Yusuf to also talk about another organ with a microvascular circulation, talking about acute kidney injury in hypertensive emergency.
Assalamualaikum and a very good morning. Thank you to Ophthalmology Department for inviting me to talk about hypertensive emergency and renal impairment. All right, so we got to talk about approach towards getting the diagnosis. I will take you back to the presentation of the patient had in 2023, where he presented in October. He was diagnosed of having hypertension 1 month. This is the history that we got from the emergency department and from the clerking that we had. I think we had reviewed the file again, and actually the patient was diagnosed with hypertension in April 2022, about a year before that. Okay, he presented to KK with high BP and was noted renal impairment and was straight away sent to the hospital. If you look at the history again, he actually complained of bilateral lower limb swelling. He already had autopnea, dyspnea for 2 and 3 months before and had it worsened for the past 2 weeks before he presented. He denied traditional medication, no history of upper respiratory tract symptoms, asthma, hemoptysis, no rashes or arthralgia. Okay, if you look back at the BP, at the investigation, the creatinine jumps too fast. In October, the day before the presentation to our site in hospital, the creatinine was 263. The other investigation, if you can see, that he has pneumochromic pneumocytic anemia. The calcium is on the lower side. The phosphate is already high, but you can't conclude that this is actually a CKD because phosphate can also become high in a patient who actually had an acute kidney injury. The albumin is still preserved, but as you can see, the protein and blood is 3+ and 3+, which is significant finding on the urine FAME. So we had 2 problems here. We have someone with hypertensive emergency. Maybe he's a young hypertension because he's 42 years old, BP is very high, and according to our CPG, or management of hypertension, this is actually an hypertensive emergency due to severe elevation of blood pressure with an organ damage, which is the kidney. The second problem, which is acute kidney injury. Right. So in these kind of cases, when should we think about secondary hypertension? Do we think that this gentleman has a secondary hypertension and not just primary hypertension? If I look at this patient in ED, I will think about secondary hypertension first because it's actually relatively young. If you look into the guideline, in the American Heart Association guideline, they don't have a cutoff because different guideline will say it's less than 30, less than 40, less than 50. But this patient is relatively young, so I might think about secondary hypertension. He has severe hypertension, we saw that, and also he has hypertension-mediated organ damage, which is acute kidney injury, that creatinine goes up to 100 to 1,000. Okay, so when you talk about secondary hypertension, you have to think about this, so that it's either renal causes, endocrine causes, vascular causes, and other causes that the patient might have. So to differentiate between this, number one, and always that we go through is the history. We take the history, whether there's any evidence of history of symptoms of connective tissue disease, and then symptoms of Cushing, like weight gain, fatigue, hirsutism, moon phases, and then whether there's any episodic hypertension suggesting a pheochromocytoma, thyrotoxicosis, and whether he had ACE inhibitor in the past or ARB, and then causing worsening renal function to suggest renal artery stenosis. Right. This patient that we had no history of this at all. Also, on your approach to this patient, you have to examine the patient, look for renal bruit, features of Cushing, vasculitic finding, and delay pulse that could suggest coarctation of the aorta. Our patient does not have all of this. So, can hypertensive on its own causes AKI? This is a study done in Mayo Clinic. There's only about 50 patients, and about 23 of the 50 patients actually had AKI. So they can develop AKI when they have hypertensive emergency. More importantly, who get this AKI? The odd ratio for someone to get AKI is 6, and it was significant if the patient has an underlying renal insufficiency, right? And then the patient who had AKI because of hypertensive emergency, they stay longer in the hospital, and they go into hospital more frequently after that. The reason for this to happen could be because of dysfunction of the RAS system, dysfunction of the autoregulation, the inflammation, the immune-mediated renal vascular fibrosis, all of them can contribute towards the acute kidney injury. But our patient is different. If you can see that the patient actually had a very high jump in terms of the creatinine. So it will make you think about whether the patient actually has renal cause of his hypertensive emergency, possibly a secondary hypertension. So we got 2 problems. The second one is acute kidney injury. So we have to approach acute kidney injury as per normal way that we approach acute kidney injury, which is your pre-renal, renal, and post-renal. So investigation was done to delineate what is the causes. So ultrasound did not show any obstruction, so we rule out any obstruction. The urine assessment to look whether the patient actually has a renal causes is there. The FAME shows protein 3+, blood 2+, and it's very increased amount of protein. The urine PCR is 1.03, which is equivalent to about 10 grams of protein a day. right? But surprisingly, the urine phase contrast is isomorphic. We investigate for any renal cause, autoimmune screening, all were negative, right? Apart from the ASR, we look for viral screening because viral can be one of the causes of GN, and hepatitis B was positive but without a very high load of HBV DNA. He's not diabetic, and the ECG shows there's evidence of left ventricular hypertrophy, suggesting that the patient might have a long-standing hypertension that was not diagnosed in the past. So again, this is the way that we go through AKI, pre-renal, renal, and post-renal. So we have probably rolled out pre-renal for this patient and post-renal. So we're going through glomerular, tubules, interstitial, vascular. So we are going to go through glomerular because the patient has an active urine sediment with blood and protein. And again, the way that we differentiate is by primary or secondary GN. And as you can see that I put there on the slides. So thing that we want to rule out is actually any systemic diseases that could have caused the patient to develop secondary GN. So this is the investigation that we did, all the hepatitis and then all the screening for the other vasculitic lesion, including ANCA and anti-GBM. Why did we do that? Because this patient, if you see him properly, can be classified as someone with a rapidly progressive glomerulonephritis, RPGN. The kidney worsened very fast. He had active urine sediment, and to diagnose it, you have to have a biopsy that shows a cellular crescent. RPGN is an emergency in nephrology. It requires urgent intervention to prevent permanent damage, and we treat with immunosuppression or plasma exchange. Okay, so if you have a patient that can be classified as RPGN, there are three causes of RPGN. This is the anti-GBM type 1, type 2 is the immune complex disposition, which is associated with immune processes, for example, IgA nephropathy, SLE, cryoglobulinemia, post-infectious GN or secondary GN because of hepatitis. And the type 3 one is the palsy immune disease. By palsy immune meaning that when you do immunofluorescence, you cannot see any active immunofluorescence that lights up during the investigation. Further, it will be explained further by Prof. Nashima after this. So we investigate for all. We send anti-GBM. Anti-GBM for this, it was negative. So we send also ANCA, and it was also negative for this patient. We did everything for SLE, which is negative. But hepatitis B was actually positive, but we now have to wait for the renal biopsy. So what you look for in a biopsy is these crescents, and also this is the crescent. This is the one that I mentioned as a diagnosis of RPGN, and also the findings on the immunofluorescence. Okay, these are the possible diagnosis. ANCA, the palsy immune, the type 3, anti-GBM is type 1, the immune complex type 2, and based on this presence of C-ANCA, P-ANCA, anti-GBM, you can actually have a go at what kind of diagnosis that the patient actually has that causes the patient to have RPGN. The principal management is urgent treatment, immunosuppression, consider plasmapheresis. You can have specific antibody treatment. And then apart from that, we have to support the patient if they have infection, if they require renal replacement therapy in between, while waiting for the kidney to recover. This is the biopsy finding. I will leave the biopsy finding to Prof. Dashima, but I just want to mention that the patient actually has a fibrocellular crescent, which is actually confirming the diagnosis that we had, that the patient actually has RPGN. Unfortunately, the immunofluorescence was not available for us to make the full diagnosis of what's the cause of the patient to develop RPGN. If you can see the progress of the patient, we supported the patient when the patient came in by doing dialysis, but as you can see, despite dialysis, the kidney actually never recovered. And because the kidney is never recovered, and also, sorry, I forgot to mention that the patient actually has a significant signs of chronicity with chronic tubular atrophy and interstitial fibrosis of 70%. So it means that the patient actually has a chronic disease and the likelihood of recovery is very slim. So due to all this finding and our full clinical assessment of the patient, we think that the patient most likely had a primary glomerulonephritis that was missed, and the kidney the effect to the kidney has already occurred, and thus we were unable to actually reverse, and we rendered the patient to have end-stage renal failure, and the patient was put on dialysis regularly since then. So in my conclusion, a young patient with uncontrolled hypertension should be considered for secondary hypertension. Acute kidney injury should prompt further investigation, require exhaustive workup of all the differential diagnosis, and more importantly, RPGN. If you see a RPGN, it is an emergency. It requires urgent investigation and treatment. It requires urgent referral to us, to nephrology unit. Thank you very much.
Thank you. I have one question for Dr. Muhammad Yusuf.
Yeah.
So basically, when he was diagnosed to be hypertensive in 2022, so at that point, do you think he should be already referred to nephrology to rule out secondary hypertension? Even before when he had the acute kidney injury in 2023?
I think this is knowledge that I also got from Dr. Hana yesterday. Apparently, he went to KK with complaint of elbow pain. So I think it was the first time that he was seen, and there was no blood investigation that was sent. So I think anybody with a young gentleman with hypertension, the thought should click in the mind of working up for secondary hypertension. At that time, more investigation should have been done, and maybe we could have found it before.
Yeah.
Yeah.
Because I think 42 is still quite young.
Yeah.
So,
Yeah.
yeah. All right. Maybe the course would be different if he was referred earlier.
Yep.
All right. So, with that, thank you, Dr. Muhammad Yusuf. I would like to invite Associate Professor Dr. Noda Shima to give us the insight on the HPE findings of the glomerulus in hypertensive emergency, or maybe RPGN.
Okay, Assalamualaikum, and thank you, Optal Department, for inviting me to discuss on the renal finding of this patient. So, I just had show you the quick view of a fairly normal renal. Okay, the renal parenchyma composed of the glomerulus, the interstitium whereby we have the tubules, and in between the interstitium you can see the blood vessel. So fairly here you can see the tubules is quite back to back. The glomerulus is fairly well. The structure is morphology normal. Okay, this is our patient. So at this low power, you can see that it is more compact compared to just now. You have more tubules, you have more structures. There is irregularly dilated tubules, and there are some glomerulosclerosis. That means some of the glomeruli already being scarred. This is the area that difficult to assess what is the main pathology, why this glom show that changes. So in this biopsy that we saw, okay, you can see the arrow. Actually, we have only 12 glomeruli. However, 8 are globally sclerosed. That means I cannot assess why these changes happen. But the residual 4 glom, they have segmental sclerosis, and 2 glom have fibrocellular crescent. This is important. Why patient having fibrocellular crescent? Okay, if you see here, this we have several stain. So don't be surprised that I'm showing different colors of my tissue biopsy, because we have to stain it to highlight the changes. So the first one is HNE, the other 2 are the silver stain. So by HNE itself, you see this rounded glom, they're already globally sclerosed. The adjacent glomeruli also are not that well preserved. It is already having these sclerotic changes. And in one of the glom, we start seeing this presence of epithelial proliferation, whereby it already have these sclerotic changes also. So we call it as fibrocellular crescent. So down here is an intact glom. You can see the difference. This is globally sclerosed. You also can consider globally sclerosed, and one is having the fibrocellular crescent. And within this glom with the fibrocellular crescent, we can see the blackish color more. That means it's already sclerotic, segmental. That's why it's segmental sclerosis. And in this view also, you see the tubules are not nice, rounded, back to back. It's quite expanded with the fibrotic background and the some inflammatory infiltrates. So what we are seeing is something that quite advanced. The changes is not just 1 or 2 these changes. That means this changes has been there for many months or years. And throughout, what we can see, the tubular atrophy, interstitial fibrosis, which is being highlighted by the Mason trichome, are quite extensive, 70%. And you can see on H&E, the small dots are the lymphoplasmacytic infiltration. Down here is a better view of a normal as a comparison. So this one is not a good kidney. It's already have that changes that has been there for quite some times. That's puzzle why suddenly have a rapid presentation. However, the background is a chronic changes. There is chronic tubular interstitial damage. Okay, again, this one is PAS, this one HNE. We tend to highlight the basement membrane to show that the tubules are atrophy, basement membrane are thickened. You can see this glom also having the segmental sclerosis. This also having segmental sclerosis. So it's difficult for me to assess what happened to the vibral glom, so-called vibral, because there are so many sclerotic changes. Could it be a IgA per se? Could it be just it's just a membranous? They're also difficult to assess just by seeing this chronically damaged kidney. However, on top of that, as the history showed, that patient having high BP. So it do show with the vessel. You can see the vessel is thickened. The arterioles are thickened. This is a normal view. I just do in the internet. You can see the artery. It don't has the internal thickening. The arteriole is nice, not thickened. However, in our case, you start seeing the lumen itself markedly reduced, moderate to severe. Obliteration of the vessels. So it means that there is muscular hyperplasia of the wall. You can see this is on the silver stain. It do highlights the thickened vessel. I don't see any thrombotic microangiopathy changes, no vasculitis changes. So at this point of time, the most I can say without the IF, as Dr. Yusuf mentioned just now, we need the IF to show what are the expressions so that we can classify what glomerulonephritis a patient is having. So what I can give is that this is a patient with a quite extensive scarring of the globe. So we call it as diffuse glomerulosclerosis, whereby 67 are global sclerosis, 33% with segmental. Part of the vibral one show a little bit of this messenger proliferation, which can be seen in not very specific finding. You can see in IgA or in minimal change also you can see. And there is presence of fibrocellular crescent. That is very significant finding. To see there's something patient is having a GN, glomerulonephritis. But in view that we don't have the glove for IF, difficult to ascertain. And somehow if we do have the biopsy for the IF study, it can be that the sample that we receive are all globally sclerosed. We still cannot assess because it's a chronic changes. The chronic change is there. But there are the hypertensive vascular changes in this kidney. So I can just offer my morphological diagnosis without the IF, difficult to say, but just bear in mind, among the GN that can produce crescent are the IgA, membranous, in rare cases can produce. So you have to have the serological correlation, you have to the IF finding, the presentation to conclude whether it is any of these diagnoses. Okay. So just a recap on what is hypertensive renal vascular disease. The changes, it can mimic like FSGS also because in hypertensive renal vascular disease, you have the global and segmental sclerosis. On top of that, you can have the duplication of the basement membrane. So it's not really specific to say this is the cause. The hypertension is the cause to the glomerular changes. It can be the primary glomerulonephritis, yeah? And it can have the interstitium and tubular changes, like in our case. And the vessels, it can have the intimal, like this is from other cases. So you can see intimal fibrosis of the artery. You can see the multilayering of the smooth muscle. The arterioles, you can see this pinkish material being deposited. That is hyaline arteriolosclerosis. We don't see in our case. And for a macular hypertension, again, the glomerular can show scarring effect. Ischemic retraction, it becomes small, it can become corrugated, and then the artery can have the meso-intimal change. This is the This is typical picture that our undergrad will learn in the Robbie's book, the onion skinning of the arteries, and the arterioles can have fibrinoid necrosis or thrombi. We don't see that. So for the renal biopsy, difficult to ascertain what is the main glomerulonephritis, but the hypertensive changes is there. Okay, that's all for me. Thank you.
Thank you very much, Prof. Nodashima. So we move on to our last presenter, Dr. Hana Azhari, to talk about how do the primary physician approach severe hypertension.
Okay, Assalamualaikum, good morning. I'm Hana from Family Medicine. Thank you very much to the ophthalmology team for inviting me to share today. So, you've often heard of primary care physicians being called gatekeepers. This is very true and very important. We have to know when to open the door, when to open the gate so that patients can receive the secondary and tertiary investigations and care that they require. If you don't do this in a timely manner, it can result in patients not receiving timely care. They can get unwanted complications as evidenced by this case. So what I want to get across in my short 10 minutes, I'm going to go back to the beginning and how we approach severe hypertension in primary care. And it's important that you know what to look for and when to escalate care. So this patient, when he presented to our primary care department, he was immediately sent to ED. However, before that, from April 2022, he had actually come a few times for various complaints such as elbow pain, abdominal pain, to outside clinics. It was usually to rule out hypertension, KIV start medication after reviewing renal profile, etc., etc. So this causes unnecessary delay, and primary care physicians, as first point of contact, we have to take onus to prevent this from happening. So just quickly going back to definitions, so we all know hypertension is blood pressure of 140 or more and or diastolic of 90 or more. And this has to happen on 2 measurements, usually at 2 different occasions. So this is quickly these different stages, but we will be focusing on stage 3, which is severe hypertension, and that is 180 or more and or diastolic of 110 or more. So with this, I want to highlight that I mentioned earlier that we need to check it twice. So you can't just diagnose hypertension from one reading, but you can see that that doesn't mean that you should be waiting 3 months, 6 months in order to get your second reading. If you have severe hypertension, blood pressure of 180 or 110 and more, you should be confirming the hypertension within 1 week and treating if this is confirmed. And if it's even more than that, you can actually treat within the same encounter when you repeat the blood pressure in that same encounter. So severe hypertension, it can occur de novo, meaning for the first time in patients without any history of hypertension, or it can happen in patients who have had untreated or uncontrolled hypertension. This is usually the more common case. But in both cases, we need to assess severe hypertension as severe hypertension, whether it's presenting for the first time or whether the patient has known hypertension. So we all know hypertension is called the silent killer, meaning that whether the damage has occurred already or whether it's going to occur later, we have to assume that it is occurring if this blood pressure is not controlled well. And of course, in this patient, unfortunately, he developed vision loss, but we mustn't forget all the other organs vision loss and kidney failure, but we mustn't forget all the other organs that can be affected. And so always assume hypertension has been long-standing and that damage has occurred. We don't know at which point the patient has come to us, whether he has been having hypertension for many years. And so we have to look for the damage that has occurred and look for possible secondary causes. So target organ damage and target organ complications are the things we want to look for. These are the organs in which it usually occurs, and complication meaning that failure has already occurred in those organs. We used to call it target organ damage, target organ complication, or end organ damage, but the more up-to-date term is HMOD, which is hypertension-mediated organ damage. This is the term that's usually used these days. And again, these are the organs that it usually occurs in. Dr. Yusuf already mentioned earlier what we want to look for, and so I won't go on with that. But what do we need to do when we evaluate hypertension? So most importantly, we have to exclude secondary causes of hypertension. We have to ascertain the presence of target organ damage or complication, as well as assess lifestyle and other cardiovascular risks. So you know that hypertension is divided into primary or essential hypertension and secondary hypertension. While secondary hypertension is the smaller prevalence of that, it occurs quickly and more severely, and it cannot be missed. So primary hypertension is 90-95%, and most people will focus on not investigating for secondary hypertension because this is the most common one, and the other one is only about 5%. However, secondary hypertension is only about 5%, but like I said, it occurs quickly, more severely, as we have seen in this case. So these are the common causes of severe hypertension. The most common out of all of these are the parenchymal renal diseases, so like glomerulonephritis. Others are endocrine causes, renovascular causes, drugs, so things like NSAIDs or illicit drug use, coarctation of the aorta, and things like that, other causes of secondary and severe hypertension. So how do you evaluate? When someone comes to you with severe hypertension, make sure you get the right history. So you're looking at the different organs that I mentioned and looking for either signs that it could be a secondary hypertension or looking for signs of target organ damage in these organs. So, we're asking about headaches, limb weakness to look for stroke. We're looking for peripheral vascular disease. We're looking for blurring of vision, new onset of floaters. This patient, unfortunately, actually, when he presented to an outside clinic, had also complained of some blurring of vision before, about 1 month before he came. Oh, sorry, no, actually 1 or 2 months before he came here. So sometimes people don't take floaters seriously, but you have to take it into context with the blood pressure and its current presentation. Kidneys, so signs of fluid overload, and then of course all the cardiac complications. So our history, we want to focus on symptoms suggestive of HMOD or looking for underlying secondary causes. Moving on from history to physical examination, always look at the BMI, always look for all the signs that I mentioned earlier in your physical examination. Always do a fundoscopic examination in all patients presenting with severe hypertension. This is often missed. Sometimes in primary care, we don't have dilating agents, so it can be missed, but you can still do it, or you refer. If your blood pressure is really high, then you refer for it to be done in secondary care. So then we move on to initial investigations. These are the things that we should be doing. Urinalysis always has to be done as well. As you can see, for the first few times that the patient presented, he didn't have urinalysis done. And so nephropathy may either be the cause, so it may be a secondary hypertension, or it may be, there may be nephropathy as a result, as a target organ damage. I liked this because it shows when you should maybe screen for secondary hypertension. It's from 2017 guidelines. So like my colleagues have mentioned, there isn't a clear cutoff as when young is young. Some say 40, some say 30. The common one is 30, but we have to look at other things. So for example, if the hypertension has occurred really abruptly, if it occurred young, if previously it was controlled and then suddenly it's not controlled, if there's a disproportionate degree of end organ damage in comparison to the hypertension, or if there's excessive hypokalemia, of course you want to look for things like Conn syndrome. And so you should screen in these group of patients. Hypertensive crisis is encompasses hypertensive urgency and hypertensive emergency. So both of these together in this range of blood pressure is called hypertensive crisis. The most important thing to remember is that you can only call it urgency when there's no target organ damage, there's no AHMOD. That's when it's hypertensive urgency. So I did see in this patient, some people labeling hypertensive urgency. It is not, it's an emergency because the patient already has signs and symptoms, SOB, visual symptoms. And so in this case, in this group of patients, treatment is different because you want immediate care to limit progressive injury. So you can see here, this is from the Malaysian CPG. For emergencies, they have symptoms and they have acute target organ damage or complications, whereas in urgencies, they will not have any, or if they have symptoms, it's very minimal. So again, if you have no clinical or laboratory evidence of target organ damage, then only you can follow your management of hypertensive urgency. This is our algorithm. So basically, you get them to rest first. You repeat the blood pressure after about 30 minutes. If it goes down, they're a responder. And then you discharge, but not just like that. You have to give them a hypertensive urgency discharge plan. And if they're and adjust their medications, because they will all address the problem if they're not compliant. So it's not just as easy as you get them to rest, they respond, and then you discharge them without a plan. If they don't respond, then you start your antihypertensives, and then you check your blood pressure until it reduces at least 10 to 20 millimeters of mercury in systolic blood pressure reduction. And if they don't respond, then you refer them. If they do respond, you discharge with your discharge plan. So these are the medications usually used for hypertensive urgencies. We usually use captopril because nifedipine causes quite a drastic decrease. And as I mentioned earlier, you don't want the blood pressure to crash too quickly because that will affect the perfusion to your important organs. So captopril is the one we usually choose. We usually start with 12.5 milligrams, and then we monitor. We can repeat that a second time, but if it still doesn't come down, then we have to refer. So 25% reduction in BP over 24 hours, but no lower than 160/100. And so you need your discharge plan, which is usually BP monitoring at least 3 times a week. They have to know when to come for help. They have to take their antihypertensives as prescribed. So you usually need to find out why is it that they have elevated BP. Is it because they're not taking? In which case, maybe you continue the same medication. Or if they have been taking, then you must add on something, not just discharge with what they have been on before. Usually we see them maximum 1 week. So we see them within 1 week, and they need to know the safety net, so when to come back in. Hypertensive emergency, I'm not going to go into detail because basically you have to refer. Hypertensive emergency means that the patient already has symptoms of target organ damage or evidence of target organ damage. And in this case, how quickly the BP is reduced depends on what that target organ damage is. You know, whether it's aortic dissection, whether it's an MI, it depends on what it is. And then only we just determine how quickly you want to reduce the blood pressure. So that occurs in secondary care. So always refer when you suspect secondary hypertension. As I mentioned earlier, when you should suspect it depends on your assessment. In resistant and refractory hypertension, in any target organ damage or AHMOD, in pregnancy, and in children and adults below the age of 30. I just want to quickly touch on drug treatment. You saw that this patient was only on amlodipine 5 with a blood pressure of like 180. So you can see here that this is from the ESH 2023 guidelines, you only start with monotherapy if the patient has a low risk hypertension and his blood pressure is lower than 150/95. In most other cases, so anyone with stage 2 hypertension and above, you want to be starting dual combination, meaning that it's either ACE-ARB plus a CCB or a diuretic, and in those instances, you can get up to 60% control. With 3 agents, you get up to 90% control, and then only you move on to your resistant hypertension. And beta blocker can be used as monotherapy or combination at any stage. This is usually for people with a higher sympathetic drive. So that's another thing that I want to address for primary care, is that a lot of the time they're started on just 1 agent, and that's just not going to be enough. So my take-home messages are always think about secondary causes of hypertension in severe hypertension. Always look for the presence of HMOD, and please do not really delay referral when it's indicated. Thank you very much.
Thank you, Dr. Hannah. So that's the end of the CPC for today. So I think I would like to conclude, maybe give a bit of take-home message for the medical students. As Dr. Hannah said, suspect young hypertension, rule out secondary hypertension. Even though secondary hypertension is rare, but it progresses rapidly and the complications is more severe. As an inpatient, he already has end-stage renal failures because of that, and he has to have regular dialysis. And eye-wise, one eye is already blind, the other eye is still holding on, but still, it's very high morbidity. Having said that, this is a rare case. So for ophthalmologist, master student, if you say proliferative retinopathy, still think of the common one, the common cause, which is diabetic, before going to the other causes. Before I end, is there any questions to the presenters? No questions? Very clear presentation. Okay. If there is no questions, we thank the presenters in the usual manner. Thank you.